ये 45
यहाँ देखिए आप पहले इंट्रो दे दीजिए।
Bismillahirrahmanirrahim. Greetings everyone. Nice to see you. I am Dr. Ejaz Vohra. Presently I am Director of Postgraduate Studies Clinical. Maybe some of you may know me. Previously I have been at Abbas Shaheed and Principal Karachi Medical and Dental College and now at Zahuddin. Today we are going to discuss osteoporosis, an important subject, especially for postmenopausal females. Osteoporosis is defined a skeletal disorder characterized by low bone matrix, that is osteoid, and reduces bone integrity, deterioration of microarchitectural bone tissue, decrease in bone strength, and increase in risk of fragility fracture. WHO already given definitions of BMD. They are based on DEXA scan measurement. Normal is when there is only one standard deviation from young adult women, that is T-score equal or less than 1. Low bone mass, which is also known as osteopenia, that is between 1 and 2.5 SD of young adult women. Osteoporosis when bone marrow density is more than 2.5 standard deviation below the mean of young adult women. And severe established osteoporosis is when it is more than 2.5 below the normal mean for young adult women. Patient has already experienced one fracture. Statistics are not easily available for our country, but 200 million people worldwide suffer from osteoporosis. Lifetime risk for fracture in the United States is hip 15.8% for white women, 6% white women, 8.5% Hispanic women, 3.8% Hispanic men, and 2.4% in Chinese women, and 1.9% in Chinese men. Generally, black people in USA have less osteoporosis. Vertebral fracture in women older than 65, this is 70% for white women, 68% for Japanese women, 55% for Mexican. There is no much variation for vertebral fracture on race and ethnicity. So in Pakistan, data is lacking. It is only based on Cancalian ultrasound. So it cannot be reliable because dexamethasone was not used as a research tool. But risk factor, say in one study, 103 postmenopausal female having head fracture were early menopause, long duration of menopause, low BMI, poor socioeconomic condition, multiparity, smoking, illiteracy, lack of calcium supplement, injudicious use of steroid, and poor visual acuity. Mean age of the study group was 64.6 years, and the average duration of menopause was 9.9 years. And 70.9% women did not exercise. So these risk factors are very common for osteoporosis all over the world. Bone turnover contributes to femoral bone marrow density in regression pattern. Low serum vitamin D and high NTX values were Indian Pakistani, more in Indian Pakistani versus American Caucasian. In one of our studies to assess bone health in healthy female, high bone turnover was seen with vitamin D sufficiency and secondary hyperparathyroidism. This is of the vitamin. You can see all the studies which have been published. It's almost 80 to 90% people are vitamin D deficiency. These are mainly women, some in healthy adults also. These are the various studies. I don't need to go into details, already have discussed. but I'm sure you'll be provided with these slides. Pathogenesis. As already discussed, it's increased breakdown by osteoclast and decreased bone mass. Accompanying figure will show how this bone growth occurs in the early age, then consolidation and the loss. Loss is less common in men, and multiple genes are involved. Collagen type A1C, vitamin D receptor antagonist, estrogen receptor genes, nutrition factor, lack of physical activities. Glucocorticoid. This is unfortunately very common in our Pakistan with so much misuse. Osteoporosis is multifactorial with the interplay of genetic, intrinsic, exogenous, and lifestyle factors. The hallmark of osteoporosis is reduction in skeletal mass caused by imbalance between bone formation and resorption. A change in either of that is increased bone resorption or decreased bone formation may result in osteoporosis. Osteoporosis can be caused by both failure to build bone and reach peak bone mass as a young adult. This is very important because those who do not achieve a good bone mass as a young adult, they are later more suspected to have osteoporosis and by bone loss in later life. Next, please. Furthermore, in periods of rapid remodeling after menopause, bone is at an increased risk of fracture because of newly produced bone is less densely mineralized and resorption sites are temporarily unfilled, and isomerization and maturation of collagen are impaired. Activation frequency reflecting bone remodeling rate increases to double at menopause, triple by 13 years later, and remain at high level in osteoporotic patients, which naturally contributes to more fragility. The receptor activator of nuclear factor kappa B, receptor activator of kappa B rank, and so many others which I mentioned. These are the ones which are responsible for osteoporosis. So types: juvenile osteoporosis, that is usually occur in children of young adults of both sex. Normal gonadal function, age of onset usually 8 to 14 years. Hallmark is abrupt bone pain and fracture following trauma. Idiopathic, this is what we are going to discuss today. It is mainly postmenopausal. Occurs in women with estrogen deficiency, characterized by phase of accelerated bone loss, primary from trabecular bone. Fracture of the distal form and vertebral bodies are common. Age-associated senile osteoporosis. It occurs both in women and men, gradually declines with aging as earlier shown you. It represents bone loss associated with aging. Fractures occurs in cortical and trabecular bone. Wrist, vertebral and hip fractures are most often seen in senile osteoporosis. Causes of secondary osteoporosis in adult. They are numerous. They may be congenital, they may be hypogonadal states, endocrine disorders, deficiency state and malabsorption syndrome, inflammatory disease, hematological and neoplastic disorder, medications, and miscellaneous. Some of the examples of the each category are given in over there. In fact, that is alcoholism and ethnicity, white or Asian are more prone, female sex is more prone, then genetic disorder, hormone deficiency naturally estradiol, and in, of course, testosterone in men, hormone excess, that is Cushing syndrome, hypoparathyroidism, thyrotoxicosis, and there are certain drugs like PPIs, SGLT2 inhibitor, SSRIs, smoking, underweight, and miscellaneous. It's a silent thief that generally does not become clinically apparent until a fracture occurs. A screening at risk population is therefore essential. So it is very important for us to recognize who are the people at risk so that we screen them and prevent fracture. Non-modifiable risk factors include personal history of fracture as an adult, history of fracture in first degree relative, white race, advanced age, female sex, dementia, poor health, or fragility. Potentially modifiable risk factor. Current cigarette smoking, low body mass index, low body weight, less than 127 pounds, estrogen deficiency, earlier menopause or bilateral ovarectomy, low lifelong calcium intake, alcoholism, and impaired eyesight despite adequate correction, recurrent falls, inadequate physical activities, poor health or frailty. Physical examination. Naturally, there will be pain, disability, and diminished quality of life, a history of loss of height, low body mass. Signs that might indicate existing osteoporosis are kyphosis or down edge hem, point tenderness of a vertebra, or a suspected fracture site. Signs suggestive of secondary osteoporosis. Signs in older patients that will indicate whichever the disease is underlying. Sign in older patients may indicate increased fall risk like difficulty in balance or gait, orthostatic hypotension, lower extremity weakness, poor vision or hearing, cognitive impairment. Sign of collagen defect, short fifth digit, dentigenesis imperfecta, hyperlaxity, hearing loss, pes planus, bunions and blue sclera, venous difficulty, kyphosis, and vertebral compression fractures. Excuse me. Vertebral compression fracture is the most common osteoporotic fracture. Symptoms of vertebral fracture may include back pain, joint loss, and disabling kyphosis, and which can, of course, lead to restrictive lung field.
कट कर सकते हैं
कट कर लो जरा, मैं खांसी जरा ठीक करूं।
देखो माइक तो नहीं चल जाता
ये मेरा पूछने से ड्रिफ्ट होती है तो ये बेशक पानी पीने की तस्वीर आ जाए। अक्सर लोग लेक्चर में पानी पीते हैं। जरा हिम्मत होना चाहिए। Anyway, we can start again, please. ये स्लाइड तो रिकॉग्नाइज कर लिए ना?
एक मिनट समय yes sir.
Despite advances in treatment, fractures may lead to disability. So, of all patients with hip fracture, 20% require long-term nursing care.
सर एक मिनट यहीं से दोबारा वो बोलिएगा
Of all patients with hip fracture, approximately 20% require long-term nursing care. Among women who sustain hip fracture, 50% spend time in a nursing home while recovering. Approximately 50% of previously independent individuals become partially dependent, and 1/3 become completely dependent. So it is very important that we must prevent fractures. Only 1/3 of the patient return to their pre-fracture level of function. So this is very important of screening and treating osteoporosis if occurs, because we want to prevent this disability. Secondary complication, of course, nosocomial infection and pulmonary thromboembolism. This again, various fractures which is given. Hip 17%, pelvis 6%, wrist 13%, spine 23%, other 41%. Along with Dr. Scan, most lab will also give you WHO fracture risk algorithm. Some of the details are given. They give you the signs and also 10-year probability of fracture. This will guide you with the treatment. Screening in men. We should not forget that that men can also have osteoporosis. Age older than 70 years, low body weight, greater than 10% weight loss, physical inactivity, corticosteroid use, androgen deprivation therapy, previous fragility fracture. This is again fracture is based on bone marrow density and biochemical. The higher the decrease in low, higher the decrease in low bone density, the increased risk of fracture. Investigation. All women 55 years age or older, that is indication. All postmenopausal women with a history of fracture with major trauma, with osteopenia identified radiographically, starting or taking long-term systemic glucocorticoid therapy more than 3 months. Many of our people get, many COPD in our countries get unnecessary long-term steroid. So the recommendation is short-term high-dose steroid. Many people with arthritis also put on steroid. And of course, there are many other conditions where you need immunosuppressive. So they also need this screening for bone marrow density testing and naturally low body pharmacology intervention may be needed. Diagnosis we have already discussed, so I just leave this slide. This is what DEXA scan looks like. A summary of list of bone formation markers is as follows. Is it, we don't need to do them, but in case you are doing research, they may help. Serum total alkaline phosphatase, bone specific alkaline phosphatase, osteocalcin, type 1 procollagen, bone resorption marker, hydroxyproline, pyrrolidinone, deoxypyrrolidinone, NTX, serum collagen type 1, C telepeptide, bone siloprotein, tartrate resistant acid phosphatase. In our normal practice, we don't do that. Management. This is very important. Lifestyle modification for prevention of osteoporotic fracture includes increasing weight bearing and muscle strengthening exercise. In old age, you also get sarcopenia. So it is very important that people maintain a healthy exercise and so that the sarcopenia is also prevented, sarcopenia. You need muscle strength exercise to improve agility, strength, posture, balance, which may reduce the risk of falls. Ensuring optimum calcium and vitamin D intake as adjunct to active anti-fracture therapy and balanced diet. Tobacco cessation, of course, in Pakistan, the religion doesn't permit alcohol, but people still take alcohol, so they have to reduce alcohol. Removing potential risk factor to avoid falls. Site will give you details how much vitamin D you need at various ages. In fact, vitamin D is these days given right from the infancy stage. Measure for prevention of falls. This is very important. The rugs and the carpet either should be removed in the rooms of old age people or they must be anchored. Most falls occur because of that. Minimize clutter, remove loose wire, use non-skid mats. In bathroom, it is very important. Non-skid mats. Install handrails in bathroom, halls and long stairways. Light hallways, stairwells and entrances. And encourage patient to wear sturdy, low-heeled shoes. Ensure adequate intake of calcium, vitamin D intake, balanced diet, perform weight-bearing and balance exercise, avoid use of tobacco, limit alcohol consumption, and of course all the measures which I have mentioned to avoid falls. One of the great reasons of the fall is benzodiazepine. So when you prescribe drugs to the old age people, ensure that your drugs do not cause falls. So benzodiazepine are very commonly involved in fractures. Vitamin D post-menopause daily requirement is 1200 milligram. If diet is adequate, then 500 to 1000 milligram. Vitamin D 800 units in daily. It should not exceed, calcium should not exceed more than 2 gram because it has side effect of atherosclerosis and calcium deposits in the arteries. In the aggregate, these observations suggest that low level of vitamin D are associated with fractures. Although the optimum serum concentration to maintain skeletal health is not firmly established, serum values exceeding 12 to 20, that is 30 to 55, are supported by observational study. The same upper boundary and whether serum 25 OHD levels above 45 to 50 are associated with. This is the safe upper boundary. But there is still controversy regarding how much vitamin D can prevent fractures and what is the optimal dose. Pharmacological therapy is strongly recommended for patients with T-score of minus 2.5 or lower in spine, femoral neck, total hip, or one-third of the radius. But you may even give for minus and 2.5 osteopenia people if 10-year probability of major osteofracture is 20%, or hip fracture is more than 3%. In our country, hip fractures are very common. So even with osteopenia and FRAX score, good labs give you, those who do DEXA scan, give you these scores. So you must give pharmacology treatment to these people also. Consider patient with a recent fracture within past 12 months, fractures while on approved osteoporosis therapy, multi-fracture, fracture while on drugs, that is long-term steroid, very low T-score, high risk of falls, a history of injurious fall, and very high fracture probability by FRAX. They all need pharmacological treatment. So these are some of the drugs. Alendronate is available in Pakistan, and generally we give them as weekly supplement. And of course, we tell patient to keep sitting. Patient should not lie down, should not walk, should not eat for at least 1 hour after taking the drug. So this is a good drug because it affects both vertebral and prevents both vertebral and non-vertebral fracture. Calcitonin, this is not routinely used. Then these are other drug, denosumab, that is not used in our country, but it is given by subcutaneous injection, not available. Ependronate is available in our country, but its effect on non-vertebral fracture is not there. So I would generally make sure that choice is the drugs which affect both vertebral and non-vertebral. Advantage of ependronate is that it can be given at injection at 3 months level. Raloxifene, this is no longer used, and of course effects are not there. Risodonate, they affect both non-vertebral and vertebral. Rosumabad, terapretide, these are not. The one drug, the zolidronate, of course it's a different name, broad name here. It is available, you can give yearly. But you don't give to people with dental infection because it can cause osteonecrosis of jaw. It is expensive, but it ensures at least compliance. And it affects both vertebral and non-vertebral fractures. While bentonate only affects vertebral fracture, which can also be given as annual injection. Anti-resorptive agents include alendronate, risodonate, imidronate, zoledronate, of which 3 are available in Pakistan. They increase bone mass and reduce incidence of fractures. Denosumab is not considered initial therapy. Selective estrogen receptors, that is raloxifene, they are not usually used. Important role in selection of hormonal therapy include potential benefit effect on breast. Cancer risk reduction, but an increase in thromboembolic evidence, and this is actually the estrogen receptor modulator. They are not good for menopausal osteoporosis, but they have got some other effects, which are, and also side effect. which of thromboembolic evidence. This is why raloxamine is generally not used. Taxophene inhibits bone resorption, reduces risk of vertebral fracture, but as I mentioned, side effect, so it generally is not used. Estrogen post-estrogen therapy, they are because of the thromboembolism events, they are also not used. Parathyroid hormone, they give possible candidates are those men and postmen with severe osteoporosis, but it's very expensive and some of them need daily injection. So generally, it is also, but people who cannot tolerate bisphosphonate, this is an alternative. Ramucirumab is not considered initial therapy. Calcitonin is not considered initial good therapy. Strontium relate, it is available in Pakistan, but it is a very weak anti-resorptive agent. Vitamin K not recommended. Tibolone reduces fracture risk, but because of the excess of stroke, the trial was discontinued. Fluid B12 androgen isoflavone fluoride not recommended. So how do you know this is the radiological evidence of osteonecrosis of the jaw? I will not go into detail, but I want you to remember when you are using annual zolinodronate, you must note they are in good dental health. Atypical female fracture because they are usually mild and this is a side effect of bisphosphonate. So you should be aware of this. These are the doses because these charts will be made available to you. So I will not go into details. How is treatment monitored? So you should repeat DEXA scan every 1 to 2 years until findings are stable. Generally, bone turnover markers are not used. If they consider alternative therapy a reassessment for causes of secondary osteoporosis in patients who have recurrent fractures or significant bone loss while on therapy. So again, while beside that, despite whatever anti-osteoporosis treatment are given, if they're not improving, then we must think of other treatment options, which I have already discussed. Duration. Generally, for boron fissionate, we advocate 5-year holiday. But if the DEXA scan shows high fracture risk, you may continue it. For zolinodronate, it's 3 years, or until fracture high risk is no longer. A holiday is not recommended for non-bisphonate anti-resorptive drugs and treatment. They should be continued if you are using them. Teriparatide and allopurinol generally are not used, but limit treatment, again, these drugs are not used here. Some surgical procedures may be used. Vertebroplasty and kyphoplasty are not recommended as first-line treatment because there was an unclear benefit and potential increased risk of vertebral fracture in adjacent vertebrae. This is the algorithm. It gives you in summary whatever we have. So you must do diagnose by DEXA scan and minus 2.5 or high fracture risk, you have to treatment. Causes for secondary osteoporosis, correct calcium vitamin D deficiency, or address any cause of secondary osteoporosis, recommend physiotherapy, and all other education of lifestyle measure, fall prevention, and risk of medication. So these are the two charts which give detail which we have already discussed. So again, this will be provided to you, so one need not go into detail. Now I've included a patient page. It's very important to educate patients. You can have a reprint of these patient page and supply to, or you can translate in whatever language patients are speaking, so that you can help them in understanding, in prevention and the treatment. It is very important that we educate the patients also and people at risk. This illustrates various types. These slides can be helpful to the patients. So regular weight bearing and muscle strengthening, enough calcium, vitamin D, this is what you tell your patients. Regular compliance with the medicine, screening for osteoporosis, no smoking, no alcohol. And thank you for giving me this opportunity to talk to you. I'm so glad because we see potential complication of osteoporosis and very sad to see people with fractures are being disabled because we know even with the best of the treatment, only one third will gain full independent status. So it is very important that we prevent fracture by screening. This is a list of further reading, all those you can really increase your knowledge. And thank you. हाफ एन आवर हो गया 40 मिनट हो गए
एंड करेंगे तो